Hello my friends, welcome back to my channel in the new video. And this particular uh, a short series of two videos will be on albumin. uh, this particular talk I deliberated during a debate, a pro-con debate on use of albumin in ICU during the recently held critical care conclave in Amritsar, organized by Punjab ICCM chapter. So let's start. So as we know that albumin is widely used uh, in ICU, and specifically I have highlighted the costs of various albumin available, and you could see that they are not a cheap option. Definitely, certainly not a cheap option. You have a significant cost involved in one bottle of 100 ml of albumin. Okay, so this is important, and these are the actual MRPs which I have myself found out from the pharmacy. Having said that, routine use is not supported in all the cases, and we will see what are the evidences, what are the harms caused, does it really improve the outcomes, and whether it is really appropriate in the setting which we think as it is. And of course, it is a need of the hour that as we have antibiotic stewardship, fluid stewardship, we may also have albumin stewardship programs. Now, what is the physiology and the rationale? Of course, it is a plasma oncotic protein, a drug carrier, and an antioxidant. It replenishes the intravascular compartment at a rapid speed with a fast intravascular expansion. It protects the endothelium and also binds to the inflammatory mediator. The biological plausibility versus the patient centered benefit needs to be weighed in the light of this physiological rationale. And where all it is administered, in your experience also you must have seen that there are many ICUs where the albumin gets used in sepsis, in any edematous patient, in patient who has albumin of say less than 2 or less than 2.5, cirrhotics, albumin while the patient gets dialyzed, and of course as some of the diuretic strategies. Now, the standard indications in the literature at present point of time is, of course, situations of hypoalbuminemia where you have a large volume paracentesis of more than 5 liters, and patients with liver cirrhosis, especially for extracorporeal albumin dialysis, and after the liver transplantation, hepatorenal syndrome, and the indication of spontaneous bacterial peritonitis, the indication is unclear, exists but with an unclear dose. So these are the standard indications of albumin in any ICU pertaining to these conditions. So this will be helpful for the critical care trainee students. As far as the SAFE trial is concerned, the famous SAFE trial which was published in NEJ, which compared the albumin and the saline for fluid resuscitation in ICU and 28-day all-cause mortality. So what they found was it was a heterogeneous population of ICU patients, and use of either results in similar mortality, time to death, use of mechanical ventilation RRTs, organ failures, and length of stay. So as you could see, albumin and saline are almost the same in this SAFE trial which we know, which was published in NEJ. And of course, as we know that if you look at the TBI patients in a post hoc analysis, the 24 months mortality was higher in the albumin group. So albumin was not safe in one subset of patient was the traumatic brain injury, and it was proved beyond doubt that albumin causes higher mortality. And another very important trial was Albios trial, which came out in NEGM in 2014, which compared 20% albumin and crystalloids. And as you could see, that there was, no difference in AKI, although as you could see that there was a higher mean arterial pressure, but the p-value was not statistically significant. Of course, the fluid balance was lower in albumin and crystalloid group, but the 28-day mortality, as you could see, in both the groups was not significant. So definitely albumin addition will not pose any benefit whatsoever, and of course it will have a brunt on the cost, as you could see. So I think the next few slides we will discuss in my next video. So that's all for now. We'll meet in my next video on albumin.